We're going to get started in 1 minute. Very good. I will get us started. Good morning, good afternoon, good evening, everybody. Thank you for joining us for this UNGA side event called the Data Pandemic. My name is Sandro Galea. I have the privilege of being the Dean of the School of Public Health at Boston University. I'm here in my capacity as chair of the Rockefeller Foundation Boston University 3D Commission. The 3D Commission is a commission that's been established around 3Ds: determinants, the social determinants of health, data, and decision-making. The purpose of the commission really is to think about and to forge a synthesis for how we can understand the social determinants of health, use data, the big data that's now in the world around us, to understand the social determinants and to inform making better decisions that keep the social determinants in mind. We conceived of and started this commission long before COVID was a glimmer in any of our eyes. And of course, we are now living in the world of COVID, which is why we're doing this New York-based UNGA side event from all our respective homes. To our mind, the COVID pandemic makes the work of the commission that much more important, because as everybody realizes, COVID is not just a pandemic that depends on a virus. It is a pandemic that depends very much on the context within which it exists. So the social determinants that surround the coronavirus epidemic have informed what has happened in COVID and have informed the decisions that we have made as individual countries and as a collective world around COVID-19. It is a moment when thinking about how data can better inform the social determinants of the world around us that can point to the right decisions has become more important than ever. So we conceived of the side event called the Data Pandemic. We knew that when we called it that, of course, everybody's thinking about the COVID pandemic, but the idea is that we think about the data pandemic because we actually are in a moment when we have more data than ever. But the fundamental question is, what are we doing with those data? Are we using those data properly? Are we using those data to better inform how we understand the moment, the pandemic of the moment, and to create decisions, to make decisions that truly advance health? We have assembled an outstanding set of speakers to talk about this. We'll start with a couple of keynote remarks, and then we are going to have a panel discussion. But more importantly, we invited people to participate in this side event who we thought intersect in their day-to-day life with the questions that the commission is asking. Because really one of the central goals of the commission is not just to come up with a report, which we shall do, not just to come up with a digital space that shall innovate on this, which we shall do, but to move forward a conversation, to trigger a conversation that we should all be having all over the world, that we should be applying the best possible data to understand the world around us, to make the best decisions possible. And nowhere and never has that been ever more clear than it is now in the COVID-19 pandemic. So with that in mind, I'm very much looking forward to today's conversation. And even more, I am looking forward to conversations that will continue with those who are participating in this in months and years to come. Everybody, thank you for joining us. I'm going to start the program formally by asking Dr. Naveen Rao to say a few words. Dr. Rao is Senior Vice President of the Health Initiative at the Rockefeller Foundation. He leads a team focused on advancing precision public health, which empowers community health workers with actionable insights from data and analytic tools to accelerate progress on health outcomes. He comes to the foundation after a 25-year career with Merck & Company, where he most recently led the Merck for Mothers initiative. Most importantly, perhaps from the perspective of this gathering, Dr. Rao is our main partner at Rockefeller Foundation, and really this commission was very much the brainchild of Dr. Rao. Dr. Rao, over to you.
Good morning, afternoon, and evening, and thank you, Dr. Galea. Truly, this has been a partnership, and I'm really proud to be here. I appreciate being given this opportunity to make a few comments at the beginning. The Foundation is a strong believer in and a supporter of the 3D Commission's work. The Commission aims to bridge gaps amongst the fields of data science, health determinants, and decision making. It is this 3D concept, and we truly are supportive of that. The Rockefeller Foundation commitment to the 3D Commission reflects a broader belief that data and data analytics are crucial to making our world more equitable. Almost exactly 1 year ago, at the 74th United General Assembly, the Rockefeller Foundation launched its Precision Public Health initiative, which seeks to leverage data and analytic tools to accelerate progress on the world's greatest public health challenges for the world's most overlooked people. We initially launched the Precision Public Health Initiative because the reality is that while data has transformed many aspects of our lives, we have yet to harness its full power to improve the health of populations on a global scale. Some people feel that we are at least 10, 15 years behind, say, weather forecasting or banking. And we shouldn't have to be in this situation. Currently, our health depends on a birth lottery. While those of us who have access to cleaner environments, better schools, and safer workplaces, to name a few factors, having better health outcomes, and it shouldn't be like this. Investments in data and data analytics are even more relevant and critical today with COVID-19 spreading across the globe. We have had to fight harder and smarter to protect our populations, and I want to come back to that word, smarter. But despite this, the virus impact worldwide has been deeply unequal. In the United States, COVID-19's data tells a clear story. People of color, namely African Americans and Latino Americans and low-income households, have been disproportionately impacted by the pandemic, losing more lives and livelihoods than others. It doesn't have to be like this. Data and analytic tools must eliminate cracks and gaps in our health systems so we can work to eliminate social, racial, economic disparities and improve health outcomes overall for all. That is something Rockefeller Foundation has tried to address through our own commitment to smart testing here in the United States. For example, with critical support from other donors, CORE and the Rockefeller Foundation have collaborated to bring testing to some of the most vulnerable populations in the United States. To date, over 20,000 people have been tested in Oakland, Napa County, and Berksfield, focusing on communities of colors and farm workers. Over 2,000 have been tested in New Orleans via mobile testing, plus a range of health and social services for the city's highest risk residents, namely those living in low-income elderly apartment buildings and homeless shelters. 5,000 diagnostic and 6,500 serological tests, plus case management and health nutrition services, alongside support for families to safely quarantine via partners like World Central Kitchen and Johns Hopkins for the Navajo Nation and White Mountain Apache tribes. Smart testing is an example of using data and technology to direct the right interventions to the right people at the right time, maximizing their benefits and also minimizing their negative impacts. For example, we know that lockdowns, while sometimes necessary, have had severe economic repercussions, particularly on low-income communities. Imagine if we use precision tools to impose extremely localized restrictions rather than resorting to blanket measures on entire cities or countries. That is the promise of smart testing and of precision public health. In conclusion, data is not only necessary to fight the pandemic right now, it is the key tool for making decisions that will avoid outbreaks in 2021 and beyond. It is apparent that the tools being developed and deployed to respond to COVID-19 can be applied to respond to other health challenges, including some of humanity's oldest challenges, such as infectious disease and maternal and child health. The pandemic has created new opportunities to act now to modernize healthcare and use data to save lives. Thank you all for being here, and congratulations to the 3D Commissions for your vital work. Over to you.
Thank you very much, Naveen. Thank you for those words. Moving along, we wanted to open the session today by asking somebody who is actively in the world of decision-making to join us. So we asked the mayor of Boston, where the commission is based, Mayor Martin Walsh. He, at the last minute, he could not join us because of a conflict, but Mayor Walsh sent a brief video to address the commission and this gathering. Over to Mayor Walsh's video.
Hi, this is Mayor Marty Walsh. Thank you to the 3D Commission at Boston University for hosting this important conversation on the occasion of the 75th UN General Assembly. The COVID-19 pandemic has been one of the toughest challenges our city, our country, and our world have ever faced. But I am proud of how the city of Boston has risen to the challenge. Our efforts are working. We've flattened the curve during the peak in the spring, saving lives and conserving valuable resources. We've reorientated life in the city of 700,000 people while keeping kids fed and engaged, caring for our most vulnerable, and keeping our city running. Our number of new cases, positive rates, and hospitalizations remain low. And we're staying vigilant in making sure Bostonians do all we can do to keep COVID-19 under control as we continue our efforts to recover from it. That means following public health protocol to keep us and our families and our communities safe. The ongoing pandemic has made life difficult and uncertain. At the same time, on a national stage, we're seeing polarizing opinions on how to respond to this virus. It's fueling division and confusion in our country. But in Boston, we are staying focused. We know that the answers are in front of us and how to keep us on the right track and save lives. And those are to listen to the science and data and keep our equity at the heart of our response and recovery efforts. This pandemic has shined a light on disparities that exist and have existed for a long time, long before this virus. We're supporting everyone who is struggling, especially people who are most vulnerable. We created a health and equities task force to address the racial and ethnic inequalities and the impact of COVID-19. We are leading in collecting and sharing data about how this virus is affecting our communities. We're expanding access to testing in the hardest hit areas. We're doing more targeting and outreach in multiple languages. We're looking at all the ways we can support public health. That means addressing the social determinants of health by creating solutions to keep people fed, families in their home, and communities safe on our roads and public spaces. Every day, we're providing guidance, support, and resources to those who need it the most. And when it comes to reopening our city, we're only moving forward when the data shows that we are ready to do so. No matter what happens, we will always put public health and equity first. As we move through this crisis, we are working to build back stronger than before and come out of the pandemic a healthier and more equitable city than we were when we entered it. That must be the goal of every leader who is driving the coronavirus response in every city and town and state all across America. In Boston, we are committed to this work, and that's how we will get through these difficult times together.
Thank you. Well, I apologize to everybody for the technical difficulties, but I'm very glad we got to listen to the mayor. I remind myself when we have these technical difficulties on Zoom that, well, we always used to have technical difficulties when we got together in person anyway. So I suppose it is all of us learning how to deal with technology, no matter which space we are in. I'm very grateful to Mayor Walsh for that message. And we wanted to start with somebody who has an executive position of decision-making right now to really just reflect for a few minutes on the moment that we are in and how data is informing what they are doing. And it obviously would be easier to do that in a Q&A, but I think Mayor Walsh touched on a number of elements of that in his remarks, and we are grateful to him and his office for making that available. We're now going to move on to our keynote speaker. On behalf of the World Health Organization, we have Dr. Samira Asma, who is the Assistant Director General for Data Analytics at the WHO. Her main responsibilities are to lead the organization's effort to establish impact frameworks of accountability to deliver the 3 billion targets, to track health-related sustainable development goals, and to generate reliable data to forecast and inform public health policy, which is directly in line with the goals of the 3D Commission. Dr. Asma brings more than 25 years experience building teams and meaningful partnership to lead public health programs and policies to create measurable long-term impact. Dr. Asma rejoined WHO in 2018 and has led the organization-wide and multi-partner engagement to develop the 13 General Program of Work, the WHO Impact Framework, and the SDG Global Action Plan milestones with UN partners. Previously, Dr. Asma has worked at the US Centers for Disease Control, where she developed global programs on tobacco control and non-communicable diseases. Dr. Asma is also a member and a commissioner of the 3D Commission. Dr. Asma, over to you. Thank you for joining us. You're on mute, Samir. No, you're still on mute. No. We just need to unmute Dr. Asma. There we go. Now we can hear you. Excellent.
Sorry about that. Thank you, Sandro, and good afternoon, colleagues. Thank you for having WHO on this panel and for inviting me to be one part of the commission. Let me begin by saying data is a powerful asset for decision making, but only if it is timely, accurate, open, while ensuring privacy of citizens. The explosion of demands for data during this pandemic is unprecedented, but data is too often not comparable, accessible, up-to-date, or reliable. This poses a huge challenge, especially for countries whose statistical systems are less well-developed. Today's global count noted a tragic figure of over 954,417 deaths due to COVID-19. While the topic of today is data, behind every number is a loved one, and we must never forget this. Thank you to the School of Public Health, Boston University, and Rockefeller Foundation for bringing to us the 3D Commission, and for the lead, Sandro, for leading us this effort on data, determinants, and decision-making, which is not only timely for now, but for taking us into the future. And I would like to briefly discuss with you the WHO's work towards assessing both direct and indirect impact of COVID-19 pandemic and navigate the data challenges that it presents. Right now, the world is not on track to reach many of the health-related SDGs by 2030. Unfortunately, COVID-19 threatens to throw us even further off track. Under the leadership of Dr. Tedros, WHO has undergone a transformation in its 70 years history to make a measurable impact. And these two words, measurable impact, are critical not only to respond to COVID-19, but also to reach the Sustainable Development Goals. Robust data systems are critical to measure the impact, and WHO's triple billion targets that you mentioned, which provides focus and fast tracks progress towards SDGs. And each of the triple billion targets focusing on universal health coverage, preparing for health emergencies, as well as promoting healthier lifestyles and healthier populations are also interrelated as we respond to COVID-19. As we take one on universal health coverage, we are seeing the challenges around access to essential health services while the countries and communities are dealing with COVID pandemic. When we look at the health emergencies population preparedness index, we know about the international health regulations and the self-reporting of countries, and we know where many of the member states stand. And as Dr. Tedros says, that the world has been woefully underprepared. But the three parts to the health emergencies index within the WHO's triple billion has to do with preparedness, time to respond, as well as prevention as we roll out the COVID vaccine, as well as prevent the other epidemics that are at risk when countries are tackling with COVID, such as measles outbreak or Ebola and others. When we look at the social determinants, one of the Ds of the 3D Commission, some of the corresponding interventions also presents a mixed picture. We see that there has been a reduction in road and rail traffic and the associated injuries and deaths. We also see alcohol purchases have gone up, especially in United States and some of the other European countries, and especially more among women and girls. Data also suggests a decline in physical activities, inducing fear, worrying also has an impact on mental health. While we see that air quality has improved, but we are also ought to be prepared as the lockdowns has been removed. So these are a mixed bag, and that's why the 3D Commission really is timely and looks into the future. While we have data challenges, I think we also have the means to meet these goals and track by addressing the fundamental data gaps, lack of data disaggregation that continues to obscure the realities and inequalities that was mentioned earlier by Naveen. As noted, WHO launched the World Health Statistics Report this year. And what we noted was that more than half of the countries lack recent or primary data on at least half of the SDG indicators. And this truly is unacceptable. And we are hoping that the triple billion target and measurement approach will support the countries. And not to forget about the invisible billion that World Bank has coined. And these are the invisible billions with no birth certification, or live without identification and die without death certificates, people who in terms of data do not exist. And this has become very apparent as we want to count accurately deaths due to COVID. These are the blind spots, and countries are struggling. While we understand the excess mortality due to COVID is going to be the way to quantify the direct impact of the pandemic, but it will take time. But also there is inherent lack of capacity in countries to report on deaths that are occurring outside the health facilities, in communities, or lack of good death registration, certification, and causes of death. I also want to touch upon infodemics, which is another big challenge that we all have faced. The overabundance of information, sometimes accurate, sometimes not, and again, aggravating the pandemic. And it is very important to provide that trustworthy source of information and guidance in a timely manner to the public, as well as through the right messenger becomes extremely important. And as we have seen in the news, both misinformation and mixed messages have costed lives. And this is a growing problem that we are seeing. Recently, WHO held the first infodemic conference with a technical consultation and a call for action. And as I said before, accurate, reliable, timely data is fundamental to improve health outcomes in both emergency and non-emergency context. So I think the lessons that we learn as we go forward is that we are working now with countries to submit mortality information directly to WHO in a timely manner, and hopefully we will make that available through the certified deaths. And we will move forward in making other tools available. WHO launched the SCORE technical package recently, which collates 90 tools for data collection. The SCORE for Health data technical package stands for good tools for reporting on surveys, good tools on collecting civil registration, vital statistics, and causes of death, optimizing routine health information systems, reporting using data governance mechanisms and data release policies, as well as enabling use of that data to drive impact and track progress. Basically, SCORE is coined to save lives and to bring back where we have started. And soon we will be releasing where each country stands in terms of the SCORE assessments that will be coming forward in October. So I would like to again thank you and look forward to continuing with the Commission proceedings. And I hope this will be, again, a future guide in terms of the cutting edge information and data that will be needed to drive and get us through these difficult times. Thank you so much.
Thank you very much, Dr. Azra. Thank you, Samira, for your remarks, for everything you're doing during this time.
Thank you.
We're now going to move ahead to a panel conversation. It's my great privilege to introduce Dr. Jeff Sturcio, Dr. Sturcio is the president and CEO of Raven Martin, a global health consulting group. Previously, he was president and CEO of the Global Health Council. Raven Martin runs the secretariat for the commission, and Jeff and I have been very much partners in this endeavor with Naveen since it started. Jeff, over to you. You're on mute, Jeff.
Another aspect of Zoom conferences. So thanks very much, Sandro. And it's really been a pleasure to listen to the remarks by Mayor Walsh and Naveen Rao and Samira Asma as an introduction to the issues that we're going to be discussing for the next hour. You know, as you've heard, decision makers must often set priorities and make decisions during health crises under conditions of uncertainty. Sometimes that means acting on too little data, but today it's more likely, as Samira was just telling us, that we have a context of an infodemic. Too much data of varying quality, and often it's presented from a particular political point of view, which doesn't make our decision making any easier. So the question, the overall question for this panel discussion is, how can health decision makers navigate during periods of crisis to find a timely path to the right decisions that will lead to more equitable outcomes in the face of these challenges? And we have a terrific panel of experts who have been grappling with these issues on the front lines, both from a policy and an advocacy point of view. So without any further ado, let me get right into it. And I'd like to start by asking Howard Zucker a question. Howard is the Commissioner of Health in the state of New York. And since arriving to that position as the head of one of the US's most populous states, he's established a network of hospitals equipped to treat Ebola. He's implemented programs to address the threat of Zika. He's spearheaded efforts to combat HIV/AIDS, antimicrobial resistance, and a recent measles outbreak. And all of that was before the coronavirus pandemic hit New York. So as Commissioner of Health, Howard, can you describe the role you've played in New York's response to COVID-19? What went well, what could have gone better? And most importantly, where do you feel that data played a crucial role in your decision-making?
Sure. Thank you. Thank you for inviting me to the panel. It's a pleasure to speak with you again, and thank you, Dr. Gillette. I think the issue is a critically important one, and I will start by mentioning that the Governor Cuomo's office and the Department of Health, we worked very closely. We decided it was important.
Howard, you've just dropped off. We couldn't hear you.
That's a little technical thing. Sorry about that. Hopefully this is better. So we've worked closely together on this issue, the governor's team, my team, and looked at the key to safeguarding public health is really to base this on data. And what we did during the pandemic was we based all our decisions, the facts, the data, the expert analysis, and made sure this was all fully transparent. We realized early on that the data, we wouldn't be able to find the hotspots, we wouldn't be able to focus testing, we would not be able to point to the areas of medical need. So we recognized that data drove our decisions and all of our actions, where we would set up testing sites, how we would determine how sorry about that. Acute seconds now. I hope you can hear me again.
You keep fading in and out.
I keep dropping right now. I'm sorry about that. It was all working fine for the last 40 minutes. Technology, as we heard. I hope you can hear me now.
Yes.
So, yeah, great. So one of the key issues that the governor had mentioned was that we need to figure out how to have surge and flex capacity. And so we need to look at the data. We need to determine how many people would possibly end up in the hospitals, and some of the predictive models had over 140,000 individuals. So we realized that that data, that information was critical to determining how many beds we would need, hospital capacity, potential ICU, ICU beds that would need to be created, diagnostic testing, contact tracing. So we looked at all this. We we realized that there were 4 critical decisions involving data. One was we need to exponentially increase our technical capacity. We need to create efficient data sharing procedures to make the data readily available. So what we did is we created a COVID-19 tracker to get this information. We also
We just lost you again, Howard.
sorry, sorry. Move to a little better reception area. It's pretty good here. And so we needed to have an early warning dashboard. We had a COVID-19 report card to look at the online dashboard for schools to determine which school and which schools can open. And we had an early warning dashboard to control, to make sure that the number of cases were not rising. We also created new reporting methods and new models to look at timeliness. And we created a cross-program effort to generate and use new data. And the way we did this was to look at quality and safety. So those were some of the things. We realized that there were many challenges that we were facing, particularly early on when these numbers were going up. But we realized the only way to do this, and the government would provide this information on a regular basis, was to be sure that we had the data available and always transparent to the public so that they could make their decisions as we made the public health decisions to move things forward.
Well, thanks. That's a very succinct and helpful summary of what you did in New York. And of course, in the US at least, most people were following that very closely through the governor's regular public briefings about where you stood. Just a related question before we turn to our next speaker. How has this experience changed the way that you'll be making health decisions in New York in the future?
So I think there's a couple parts to me. What have you seen from this COVID-19 pandemic that you think would be helpful moving forward? And what I've seen is that there is a silver lining here, and it's been discussed by some of the other speakers, is the issue of the health inequities that do exist here in the United States. And I think that this COVID-19 issue uncovered a lot of that. For example, going back to the data, we realized that the antibody levels of individuals in certain zip codes in New York City were much higher than other areas. Then we realized that some of the individuals who live in that community are the essential workers, individuals who were probably exposed to coronavirus early on before we even knew the severity of the illness in the United States. And that goes back to some of the, firstly, exposure, but we also realized that there are certain health inequities that exist. We need to tackle this. We need to tackle it as a society. We need to tackle it, obviously, in order to provide better care. These go back to the issues of social determinants of health. So I think that what we will find moving forward is that this will provide an opportunity for us to look at how to prevent illness and to make sure that those inequities are resolved.
Well, thanks. And that's an important insight. And I think it's, you know, it's odd to talk about a silver lining in the COVID pandemic, but I think if it does really force us to pay more attention to social determinants and to health inequities, that will be a good thing for the health of all in future years. Let me turn next to Eduardo Gomez. Ed has to leave for a teaching obligation just around 9 o'clock, so I wanted to make sure that we have a chance to hear from him. Ed's an associate professor in the College of Health at Lehigh University in Pennsylvania. He's a political scientist by training and conducts research on the international and domestic sources of public health policy reform with a focus on high-growth emerging economies. And he really looks at the political and social determinants of health, trying to figure out how these particular dimensions of the health ecosystem have an impact on outcomes. So Ed, let me just ask you a question about a recent essay you wrote that was titled, "Politics May Kill Us, Not the Coronavirus." That's certainly a compelling title. Could you explain what you meant by that and how the division along political lines has had an impact on hampering the response to the pandemic, and how data might play a role in this division and also offer us a way out?
Great. Thank you very much, Jeff, and thank you all for taking the time. Excellent round of discussions today on this critical issue. The strategic usage of data certainly did play an important role in explaining these partisan divisions and complicating intergovernmental coordination of response to the COVID-19 during the initial days of the pandemic. First, it seemed that President Trump was focused more on his interpretation of the initial mortality data in order to support his views that the virus was not as serious as the common flu. Indeed, in March, Trump initially made the claim that more people were dying from the common flu each year when compared to the COVID-19 situation, and that we should not close down the country because of this. Of course, at this time, we still do not know the overall death toll of the COVID-19 situation. So in essence, during the early days of the pandemic, President Trump seemed to be selectively interpreting the data to support his claims. On the other hand, during this period, the scientists appeared to be focusing more on escalating number of cases and the growth rate of cases, primarily in the West and the state of Washington and New York. Over time, the scientific community began to emphasize the data showing that the virus was indeed more lethal than the common flu. The scientific community and those politicians in agreement with these views began to use the data to call for the expansion of testing and face mask use. These views, based on the data, contributed to differences in opinion with respect to policy between the president, the scientific community, and those politicians supporting the scientific community's views. At the same time, the governors of the key states, such as New York Governor Anthony Cuomo, was agreeing with the scientists on the data trends and the need to increase testing, social distancing, and face mask use. Governor Cuomo and the governor's views about the data and the appropriate response certainly led to conflicting views and contributed to the delays in the federal government's assistance to the states during this period.
Yeah, no, thanks, Ed.
Sure.
You know, I wanted to just build on the comments that you made there and also link back to what Howard Zucker said about how the response to COVID and the way that they were using data really illuminated the disparities in care and that was occurring in communities of color and among essential workers. And we've seen more generally that, you know, in the past few months, certainly in the US, there's been a lot of attention to systematic racism and what impact that's having on health. You know, what advice do you have as a political scientist on how policymakers can use data on social determinants to make sure that there are more equitable policies in place and that we really try to make sure that no one's left behind in the response to COVID?
Thank you, Jeff. That's an excellent question. There are a variety of ways. I mean, I think that policymakers more than ever need to work with the scientific community to ensure that they obtain data that focuses on the broader social determinants of health. Policymakers need more rigorous data, of course, on the relationship between poverty, inequality, and COVID-19 pandemic. And this needs to be done in order to ensure that we obtain the most accurate data possible on how these conditions are making the COVID-19 situation worse in some communities versus others. And with regards to the communities of color, policymakers at all tiers of government need to ensure that they are focusing on these communities in order to obtain as much data as possible on several key issues, such as the number and availability of COVID-19 tests being conducted in communities. We also need more focus on the ability of these groups to obtain testing and other healthcare services compared to the rest of the population, how they're compared to the other population groups on this issue of being able to obtain tests. More than ever, federal, state, and municipal policymakers must make a proactive effort to work closely with these communities and to learn about their particular situations, emphasizing documented details, learning, and making decisions on qualitative data. I think that policymakers need to work very closely with researchers conducting qualitative research, going into communities, doing a lot of focus groups, obtaining data from focus groups, and establishing linkages with these groups through different commissions or activities in order to obtain these detailed information on the differences between these communities. This can be achieved by working with population health scientists, NGOs, and activists to organize workshops and focus groups and studies that provide this in-depth analysis. For example, researchers within my institution, the College of Health at Lehigh University, is starting to do this kind of work in our local community here in Lehigh. And I think that universities have an obligation to start working with policymakers at the local level and different partnerships to provide them with this critical data on disparities between communities and addressing the social determinants of health.
Well, thanks, Ed. And you've mentioned two key aspects of this that I'm sure we'll come back to. One is, you've just been talking about the need for disaggregated data sources. And that was something that Samira Asma mentioned in particular. And also, you've talked about how communities have an important role to play in helping data scientists to construct those sorts of data sources. And we'll want to come back to that when we hear from Katie Dane in a little while. But now let's just head across the ocean to Africa. And I'd like to ask some questions of our two members of the panel from Africa. The first is Githinji Gitahi, who's the global CEO of Amrit Health Africa. And he's been very active recently in these issues for two roles. He's on the governing board of the African CDC, and he's also co-chair of the steering committee of Universal Health Coverage 2030, a World Bank and World Health Organization global initiative to promote universal health coverage. So Githinji, if I could ask you first, in the context of your roles at Africa CDC and at AMREF, which data sources have you found to be most persuasive in helping to advise African leaders and ministries to take action on COVID-19?
Thank you, Jeff. And again, a very fascinating conversation here, because this has been a really difficult area of data for decision-making for COVID-19, especially because of the speed of evolution. And also because COVID-19 has really not been a health crisis. It's been beyond health, socio-economic crisis. And therefore, we found at Africa CDC and also within many governments that the sources of information needed to make decisions was beyond what was available in the health sector. And correlating that data and even finding it was very, very difficult. So we found ourselves, Africa CDC, initially, we started to just offer weekly and daily reports on, cases, case fatality, where they are, those simple charts. And this data became very, very important for governments to cross-tabulate and to see where they are and what's going on. And also we started to provide data on testing. Which country was testing, how much. And that also provided a base for countries to make decisions around, their shortages, what was happening, their own capacity shortages that they were having. And then, it became very apparent that this was not adequate, that we needed to move on, to new conversations on the data. One of the things that Africa CDC did very early is to define the strategy, which said we want to focus on three things. One, we want to focus on preventing transmission. Secondly, we want to focus on preventing death. And thirdly, we want to focus on preventing social harm. So these three pillars kind of guided the kind of data that was needed. In preventing transmission, the daily reports were important, but we found that there were major gaps because it was very difficult to compare data from one country to the other because the testing capacities were so different. So when you said that this country has this number of cases, but their testing per million is 5, another country has a testing per million of 1,000. So the differences in the data became so significant that there were major challenges in terms of how to interpret this data. The next source of data that we found that was useful was surveys. Basically going out and working with partners to talk to communities and find out about their views on closure of churches, their views on lockdowns, their views on curfew. And we found that actually majority of the people were not worried about the virus itself. They were more worried about hunger. And this was important to governments in terms of deciding what do we do and what do we focus on. So whereas governments initially were too focused on sourcing PPEs and test kits, you started to see governments now shift to social support, for communities, and that was really, really significant. The other one was about commodities. that governments, because Africa is not one country, you have over 50 countries working together, and then you have all these commodities coming in. You have different types of tests, and the government doesn't know, do I take this kit or that kit or that kit? So we found that providing governments with criteria on tests and which ones were reliable and which ones were not was very important data for government. Just making sure that we tell governments, we assist governments in terms of choice of kits and all these things. But maybe I would like to mention as I close that we found several problems even with this data processing. One is what I mentioned, that the sources were immense. We needed data from Google and Apple in terms of mobility. It wasn't available for many countries. You could only find, for example, Apple data on mobility on 4 or 5 countries across Africa. So even trying to see the impact of the lockdowns on people's mobility was not available. That data was not available for majority of the countries. We found that there were multiple pandemic predictive models, and government did not know which one to use. So you found a model from this university, a model from that scientist, a model from another group of universities, and some were predicting completely different results. And therefore, government didn't know which of these do we follow. That was problem number 2. And the other problem was about rapid evolution of the pandemic, and therefore, governments investing in areas that quickly were overtaken. So we found that governments were predicting huge numbers of positive cases, therefore building isolation centers, and then new guidelines come on about home isolation. And now they didn't know what to do with the investment that they had made. So again, the processing of data in real time. So there are 5 words that I can use to summarize this. 1, the speed of data. Secondly, the context of the data, which is an issue I forgot about. We started very quickly weekly meetings with the government so that the data could be explained. Therefore, there was the purpose of stories and quantitative data beyond the qualitative data, just beyond the quantitative. Then learning and credibility of the data. I think I would like to stop there because I'm sure there will be questions coming. But this is what we found, and this is what we are still struggling with up to now.
Well, thanks, Githinji. That's really a fascinating set of insights into the practicality of making data available for decision making. One theme or one thread that you touched on that I think we've heard from others as well is, in this world in which we face on the one hand a glut of data or an infodemic, it turns out that for basic information, particularly when you're looking at it at a continental basis as in Africa, you simply didn't have the basic data you needed to compare between different countries. And that seems to me a paradox of the data pandemic that we're in. And it's important to be able to provide that information in context as well, as you said. And then Githinji asked about the questions this raised. Speaking of questions, I was remiss in not mentioning earlier that as you're listening to the discussion, we're going to have time in a few minutes for the audience to participate. So please, at the bottom of your screen, you'll see a Q&A button. Please type in your questions there, and then we'll take questions from all of you and pose those to the panel in a few more minutes. Our next speaker is Alicia Laurie, who's the head of the Surveillance and Epidemiology Department at the Nigeria Center for Disease Control. And she's worked on the management of epi data and the formulation of policies and operational guidance for priority diseases, including epidemics. Elise, let me ask you, through your leadership, Nigeria's done a good job of managing certain health disease outbreaks in recent years. Famously, you were able to stop the Ebola outbreak in its tracks when it hit West Africa in 2014 to 2016. And what lessons have you learned about dealing effectively with health crises like that for COVID-19 in Nigeria? And what kinds of data have you found have been most helpful in working with policymakers to make the right decisions in the middle of a crisis?
Yeah, thank you. I'm really happy to be with this discussion. And I just want to give us a background of the organization. The Nigeria Center for Disease Control is the National Public Health Institute for Nigeria, and its mandate is actually to lead the preparedness, detection, and response to infectious diseases and public health emergencies. And so the mandates of the center major mandate is core function are evidence-based and data-driven. And so the data generation and quality optimization is the epicenter of the organization. And so the development of an effective surveillance is very core to the organization. So I'll just use the Lassa fever outbreak that we experienced in the last few years as an example. Now, I'm sure most of us know that the Lassa fever the virus was isolated from one of the communities in Nigeria called Lassa, and that was discovered in 1969. But over the years, we've always believed that the virus or the Lassa fever outbreak is just limited to some certain areas. But with the improvements in the strategies for surveillance and the review of our strategies, we were able to identify that the outbreak is actually in most of the states in the country, and that has covered the whole country as a whole. And by last year, 2019, we knew that the Lassa fever was all over the country. And so that's actually determined a lot of decision making in the country. Initially, we had one laboratory that was testing for Lassa fever in the country, but with this detection and identification of the use of data to be able for us to know that it's all is endemic in the country, we were able to activate 4 more labs to test for Lassa fever. Now for the Ebola, yes, Ebola, we had a strategy. We were lucky in the country. Then that was when the institute was initiated. And so we were able to take a lot of action with our partners to be able to, contain the disease. But then other disease outbreaks that we have been experiencing, the data that we have generated from those outbreaks have really helped us to make a lot of review our policies. And that had made us to be able to review our policy in terms of the IPC, infection prevention and control in all the major health facilities, because that's one of the major issues that we had faced in the country, health worker infection, and that's as with all the outbreaks and the data. Then for Lassa again, initially we thought it was seasonal, that we had Lassa in the dry season. But with the data that we generated and we were able to, we now know that Lassa fever is all year round, that we record cases all year round, but we have peaks in some certain seasons, and that's in the dry season. That's between December to April. And so that has helped us also to review our policies in terms of our interventions. So the data has really helped us a lot in so many ways. Now for us to get the data and also respond real time, we were able to get a software called SOMAS that gives us real-time information for data management, and that has helped a lot. And for SOMAS, it's multi-purpose, that is, we collect data and we also manage the outbreak with the use of the data that is being collected. Now, this data is collected from various sources. That includes the laboratory, the treatment centers, and the surveillance, epidemiology surveillance data. And we have community data that is collected from this platform. So that also helped us to make a lot of decisions. We were able to sensitize more people, and the communities were more aware of Lassa fever. And so we got more cases being reported. I'm sure if you look at our data for 2019, it was quite high. But for 2020, it's even higher than what we had ever recorded. And so we're getting more data, from awareness and then from the policies that we have reviewed and developed in the past years through the use of the data that we have generated. Now for COVID, we have learned a lot of lessons from Lassa fever outbreak, and that has helped us also to be able to contain and manage the COVID pandemic in the country. Now, one of the areas that we were very strong at is in the contact tracing, because for Lassa fever, we do a lot of contact tracing, And so that helped us to be able to, continue with that strategy for case finding, and also to follow up with cases that have had contact with confirmed cases. So that's helped us. When we got into the community transmission, the data we generated actually helped us to determine when community transmission started, because we had a lot of percentage of confirmed cases that we could not identify their source of infection. That's also changed our policy in terms of the management. Initially, everyone goes to the isolation center or treatment center to be managed, but with the community transmission, the number of people to be, most people preferred to stay at home, so we needed to develop home management, and that's changed a lot of policies for us. So we're still working on it. We're still managing, we're working on the data that we have generated, and these sources, the main sources of data for us, because there was a time we had some issues of mortality in a community that we could not identify. So mortality data is an issue, is one of the sources that we look at. Of course, morbidity and the geographical spread is something that is very important for us. And the socioeconomic impact data is a major source of data for us, because that helps us to determine when to take some drastic intervention. The other time we had a lockdown, and during the lockdown we had no movement, and so there were so many social activities that could not hold. And so, but with the data that we were able to gather and some of the issues that were raised, you needed to go into the social, economic data. We had the president set up, there's the economic group that were monitoring the data in the country. And so that also helped us to ease off the lockdown, to be able to help the people to get their source of income, because the source of income, most people are daily workers. The source of income is their daily income earners. And so that's determined some of the interventions that we were able to take in the country as a whole. Thank you.
Well, thanks so much for those insights based on the experience you had with Lassa fever. One of the things that I thought was most interesting about your intervention is that you made clear how complicated it is just to get the facts in real time, that you had to use surveillance data, laboratory data, treatment centers, community data, social and economic data, that it's no simple matter to collect enough information to really know what's happening and then to make decisions on the basis of that. Our next speaker is Dr. Jeanette Vega, who also has experience with that complex relationship between data and decision-making. She's the Chief Medical and Innovation Officer at Red de Salud UC Cristos, which is the main private health provider in Chile. She's had decades of experience in international health, has previously worked at the World Health Organization, the Rockefeller Foundation, and she's been director of the Chilean National Health Fund. So Jeanette, the question I'd like to pose to you, building on what we just heard about Nigeria, is that, at the same time that you're dealing with health emergencies like COVID-19, in the role you had at FONASA and in the work you've done in recent years, you still have to provide continuous health services for other conditions. And so it's a challenge to balance what you're going to do to meet the crisis with making sure that the rest of the health system doesn't fall apart. So what sort of data do you need for those decisions? What information do you wish you had at the time?
Thank you, Jeff. Well, we have had the experience here in the COVID-19 pandemic, where in fact we have had the issue that we need to change the way we are providing funds. The problem with that is that at the same time that you are having the COVID-19, you are having this epidemic, this social epidemic, that means people are losing their income because they are becoming unemployed. And also you have people that are not being taken care of for the existing diseases because everything is related to COVID now. And in addition to that, you are having to predict what is the money that is going to be needed for next year, where you are going to have a double burden. So the way that the government has dealt here with that issue is that basically they stop all investment first. Secondly, they pull monies from all the sectors and redistribute the money. In fact, 1 point of our GDP went to fight COVID up to now. And the thing with that is that we have had other sectors that are having issues as well. And when we talked about social determinants, labor market, for example, is one of those. So in addition to change the policy of money allocation, because we have used some of our research and also used to get some loans from international organizations, but at the same time, we need to make sure that we get data not only from the health sector, with all the complications that the data from the health sector has, but also from other sectors. In our case, for example, the effect of on unemployment is around 3%. I mean, we were like 7% unemployment, even less, 6% unemployment, and now we are 13% unemployment. At the same time, we need to get data related to the effect on the income. And we know that the GDP in my country will drop 5%, the total GDP by the end of the year. And then at the same time, which are the data that are more difficult to get, is the data related to families and how families are coping. So if we're talking about social determinants of health and data, this is a huge challenge. Now, the kind of good news is that right now nobody can challenge the notion that social determinants of health and having good health is a precondition for economic development. So there is a window of opportunity there because the argument has been made in practice. Now, before stopping, I wanted to address one question that I think is very important here, which is somebody's, Jafet, I think, is asking, how do we fight what appears to be a trend of using data to support decisions already made? Simply said, leaders make the decisions and the staff is tasked to find the data evidence to support it. And I do think that that has been a huge problem all over the world because this pandemic has become so political, rightly so, that is being used as a political weapon in some way. And countries are basically fighting to show that they are responding to the epidemic in a wonderful or in a good way, when we all know that at a global, and in the global scenario, and then as country level, we have made a pretty bad job because we were not prepared and because basically we're not able to fight these epidemics in a different way than what we had done 100 years ago. So two big issues here, issues related to preparedness and then predictive data, which comes up from here. How can we predict instead of basically respond? And secondly, how can we make sure that we have data to really capture all the dimensions of the epidemic and not only how many deaths and how many people got COVID. Over.
Yeah, no, Jeanette, that last point you made is so important. And what you've done, you've also built on earlier comments, and now you've shown us that the question of what data do we need to make effective decisions is even more complex yet. Namely, it's not enough just to know about the disease and its direct impact, but you also need to know about the social and economic context. And that's, I think, a really important point. And that brings us to our last speaker, who's Katie Dane. Katie's the Chief Executive Officer of the Non-Communicable Diseases Alliance, and she's widely recognized as a leading advocate and expert on NCDs. She's been a member of the WHO Independent High-Level Commission on NCDs, and recently a member of the Lancet Commission on NCDs and Injuries of the Poorest Billion. Katie, several several of our speakers have pointed to the importance of really linking all of these concerns about appropriate data and the right decisions to the needs of communities. And that's really what you and the members of the NCD Alliance have focused so much attention on over the last 10 years. So how have you used data to continue to advocate for funding of NCDs during this outbreak of COVID-19? And what kinds of information have you and others in the NCDA found most influential in persuading decision makers to take the needs of communities into account as they address all of these health issues?
Thanks, Jeff, for the question. And I think I'll start by just really picking up from where Jeanette finished really with her response, which is that I think COVID has been a really revealing case study of how data, science, politics, and policy are all really interconnected and essentially really indivisible. You know, and we see this at the national level where governments are setting national policies and strategies in response, as well as at the multilateral level where decisions on international cooperation are being made. And I think what COVID has really reinforced is that, you know, data is important, but it doesn't always speak for itself. And that there are many other factors at play which are really influencing decision makers and policy. And we've seen this all along. It's not, you know, unique to COVID, but it's really been particularly exposed during this pandemic. And in many ways, we've always kind of viewed policy making as kind of a melting pot of problems, of politics, of policy processes, as well as, you know, biases and vested interests of many different actors within that melting pot. And I think what's clear during COVID, amongst other global health, you know, policy processes, that there often isn't a really causal relationship between data and decisions. Often, as Jeanette just said, data is used after the fact to validate decisions. And as there's so much data out there, as has been raised already, it's relatively easy to be able to cobble together data that really supports a decision that's been made. Also, often the primary issue at stake, for example, health within the context of COVID, isn't necessarily the driving force for decisions. We know that all policy involves different trade-offs, and often there's a great complex web of issues at play, whether it's about the economy, trade, politics, and quite often what we see is that health and inequalities kind of, you know, come somewhere at the bottom within those decisions. And also, you know, during kind of a pandemic such as COVID, I think it becomes even more complicated due to, as other speakers have raised, this kind of essence of speed and quick decision making. And as a result, I think what we've seen in many countries is quite unfortunate in the sense of decision making becoming extremely opaque, with, you know, the general public as well as scientists in many ways being kind of left out in the cold to some extent. And ensuring the independence and transparency of data and decision making has become quite challenging. So against all of that kind of backdrop, how we as an organization have used data to advocate for NCDs during COVID, I think there are kind of four main ways I'll just highlight very briefly. And first, we ourselves have collected and used data from our network to understand the issues, as we're a global civil society organization with members around the world. Secondly, secondly, we've used data to really make the case for governments to incorporate NCD considerations within their COVID response. Thirdly, you know, civil society has a role in kind of filling gaps where we don't have data, and obviously that's been a major challenge during this pandemic. And I'll talk very briefly about that, as well as fourthly, kind of leveraging the pandemic in a way to expose some of the holes and the shortcomings in surveillance around NCDs that I think Samira Azma brought up very clearly at the beginning there. But just to go through those very, very briefly, in terms of number one, understanding the issues, I think as Gitinji already highlighted, the importance of kind of surveys and consultations with communities to understand the issues is really important. It's great to have, it's really, really important to have, you know, quantitative data and modeling around the impacts of COVID, but to really be understanding right now what are the challenges and needs of people most affected is critical. So through surveys, we've been able to do that. Secondly, in terms of data to make the case with governments, I think it's important just to highlight the variety of data to make the case. Epidemiological and economic data is obviously key. We always say that, we need evidence for the head, the heart, and the pocket to really make governments act. But it's also how you frame the data as well. And I think we were very sensitive to the fact that during the early days of the pandemic, governments were being, really rocked by this pandemic and getting the infrastructure in place. And so timing of actually kind of pushing the points around the linkages between NCDs and COVID. And in many ways, you've got this syndemic of inequalities, non-communicable diseases, and COVID all swirling around. And in a way, you can't really dissociate any of those elements, and that you do need to invest in healthy populations in order to be prepared for future pandemics. And then in terms of filling the gaps in data, what we've done is both, worked very closely with organizations that are best placed to be, generating data on the areas that we saw as being an issue. For example, disruption of NCD services that we were seeing around the world, with WHO producing a rapid assessment, which has been extremely helpful for advocacy. But also ourselves kind of, collaborating with research organizations to actually undertake data generation ourselves. And one example of that is that we've been looking at how the unhealthy commodity industries have been really leveraging the pandemic for their own interests through kind of crowdsourcing of examples from around the world. So I think I'll pause there, but just a few kind of examples of how we've used data and the broader context.
Oh, Katie, thanks so much. That was a really concise and comprehensive review of how data can be put to use. And I loved your comment at the beginning that data are important, but they don't speak for themselves. And your intervention exemplified why that's the case. Well, we have just a few minutes left to bring audience questions in. Jeanette's already mentioned one, and Katie also that came from the audience. And Katie's actually just responded to another question that came up, that people were interested in knowing how you can link data sources and data use to the needs of communities. And I think Katie did a good job of talking about that, as did Gathinji and others. One of the themes that ran through a number of the Qs that came up in the Q&A is really the politics of data for COVID-19 and other health crises. And that was something that Jeanette raised as well, in terms of our governments making decisions and then searching for the data to justify those decisions. But let me just quickly summarize a couple of the questions that came up. From India, there was an interest in disaggregated data, because without those kinds of microdata, it's hard to do meaningful analyses at the community level that get at the differences and the different determinants of health that affect different subpopulations in India. And this questioner said that there really seems to be a question of political spin, if I can use that colloquial term, on how data are generated and used. And he wanted to know, can we depoliticize data? Someone else asked, the Kenyan government has been accused of manipulating data to suit the government's position on COVID-19. That's not, I'm shocked to hear that people are concerned about that. In the US, I dare say that that's also been a challenge and a concern. And those aren't the only two countries where populations, communities are not sure that what the government says is trustworthy. So those are two questions. And the third had to do with how can politicians, how can we make sure that data from WHO are used effectively and generally around the world, and don't get crosswise with political concerns in different countries. So those were 3 or 4 questions that were all about the politics of data use. So briefly, we might, Howard and Gathinji, Samira may want to comment on that, and others may have comments too. But why don't we begin with whoever would like to just comment quickly on those questions.
Okay, I could go, Jeff. And of course, there's an issue of, in fact, I can address the question that's asked by my colleague on Kenya's situation, and you've also tried to address it, is the issue of data ownership and trust. And this is not only within COVID, it is general that, in fact, on the UHC 2030, when we look at data on UHC monitoring, for example, and you get data that comes out from countries and is presented to the UN General Assembly through the voluntary national reports or any other instrument that exists, there is a big need to actually have that data owned by the people, by communities, so that there's trust on the data. The challenge we find is that you see data presented, and when you talk to civil society, they say, that's a lie, that's not true. You know, when the governments present and say, you know, we've reached this number of pregnant mothers with the services, and then the community themselves say that's not true, you know, who has been reached. Right now, this is the big issue, and I think that it is the issue that we need to address, and the way to address it is what many people have raised in terms of every data set needs a story. You know, we need to also have, to increase the use of qualitative data, surveys, community voices, and stories, because then this is what also increases the ownership and trust of the data. I think that's what I would like to say, that data without ownership and trust of the people it represents is basically just a piece of numbers.
Thanks. Thank you for that comment. Anyone else on that question? Yes, Samira, please. Oh, you're on mute. Still on mute. Still can't hear you. Oop, help is on the way.
So Jeff, in the meantime, if you want me to make a quick comment.
Please do. We'll come back to you, Samir.
I just wanted to go back to the issue of disaggregation of data, because I do think that there is an issue there that we need to discuss. In fact, the question becomes, what is the level of disaggregation that we need to make decisions? Because this is not about research, this is about making decisions. And we already know what are the social determinants that we need to explore. And in most of the countries, even with ecological data, we have a good understanding on where the pockets of deprivation are. So I would say that more than disaggregate data to the individual level, what we need to make sure is that we are able to monitor those deprived communities and make sure to understand what is happening there. For example, the favelas in Brazil, or the populations here where we have a very, very, very poor populations, we know that those people, for example, have had to continue working. We know that the mobility of those people has continued. We know that they have lost their work in a higher percentage of the others. So the question becomes there, how do we identify those buckets in order to make sure that we get actions? And the action is not on making PCRs, the actions is on making sure those people survive the COVID epidemic. So I do think that the disaggregation of data, again, is related to what do we want to do with those data. And we are talking about policies. It doesn't have to be necessarily on an individual level. Over.
Yeah, no, it's a very important point. And Samira, have you been able to unmute? Yes, try now.
Is this better? Can you hear me?
Yes.
Fantastic. The point I want to make is that data should belong to the countries. What we are seeing at the surface is the reflection that there is not enough capacity as multilateral partner organizations or academic institutions. Perhaps we have not invested in a sustainable manner countries' capacity to strengthen data and health information systems. That is a glaring gap that is becoming very obvious as we are going through the COVID-19 pandemic, and this is the only chance, hopefully, we have to fix it. In terms of the data use, we need to also simultaneously use the data that is available and also have proper ways to estimate and to record and to capture, curate, and communicate data. I think the point is very well made that data is abstract unless it is said in a way of a story. In terms of use that was mentioned, the work that WHO is trying to move forward with the member states is strengthening the data systems, as well as promoting use through these measurement framework, establishing baselines, targets, trajectories, but not doing an after-action report, but doing a real-time stock take as to why there has been no progress on a particular aspect. So that whole real-time review is what is being worked towards, this triple billion construct, where Dr. Tedros is going to be reviewing each of the billion progress. Simultaneously, countries are going to prioritize the areas of work and do a similar exercise with either the heads of state or the ministries of health. So that is where the progress is going with regard to data collection, curation, to communication and use, but underscoring the point that data belongs to the country. Privacy has to be taken care of, but at the same time, data is a public good and it must be shared with proper checks and balances. Thank you.
Thanks, Samira. Howard, did you want to intervene?
I just wanted to say that the comments about trust, I think, are central to everything. If people don't trust those who are providing the information, if they don't trust those who are in the position of authority, then the data that comes out, they won't trust that. And I think the complexity here is that also the data keeps changing, the information keeps, more information comes in, so we have more data and decisions will change as we get more data, as others have spoken about. And I think that the trust is at the core, because if people realize that, well, we have more information, the decisions will change, but we trust those who are providing that information to us, I think it goes a long way, whether it's at a national level, international level, or even a local level.
Yeah, no, I think that certainly is a point that's been implicit in this discussion. This is the time where it's difficult as a moderator because we could go on for hours. There's still so much more to be said. I want to Howard will have to have the last word though, because we've run out of time. I want to thank all of you for your really insightful contributions to this dialogue. And we've covered most of the questions that came in from the audience. As I said, a lot of them revolved around the use of data and the political context in which data are used in a health emergency like COVID-19. But each of you has had important points to make, and I want to thank you again. Now let me hand over to Sandro Galea, who's going to attempt the impossible task of summarizing what we've done over the last hour and a half.
Well, first of all, thank you, Jeff, and thank you to the panelists and thank you to the speakers. It is actually impossible to summarize what we've done the past hour and a half, but if I may extract just 3 themes. You know, the commission is centered around the notions of how data about determinants can inform decision-making. And in some respects, each of those aspects can seem dispassionate, can seem neutral. But I think what emerges from the conversation is that none of them actually are dispassionate, none of them are neutral. That data by itself is not a neutral concept. Data has valence. Data ultimately are collected about people. And unless those people trust that the data are going to be used to advance them and advance their health, we are losing tremendous opportunities in data. I think Dr. Asma made a very nice point that ultimately data is about telling stories. And it doesn't matter whether you're an epidemiologist, you're telling stories through a 2x2 table, or whether you're an anthropologist telling stories of lived in lives, you're ultimately telling stories. So the theme that emerges for me is that we need to make sure that we use data to illuminate people's lives so that those who are in a position to make decisions can make the right decisions to improve those lives. And that is, I think, a real evolution in how one thinks about data. That's a real evolution in how we think about data rather than it being something dispassionate that is in a box over there. So I think the central point is the data is very much living and it lives with us all globally in whatever our context is. That's number one. Number two, this theme emerging again and again, there are a lot of data. We have a lot of data right now. We have data, we have technology. The issue is not so much having the data. The issue is being smart about what we do with the data. And there was implicit when everybody said is, we are far from that we are far from that. We all know that we are swimming in data. And you know, I don't think anybody said this explicitly because I think we're almost a bit embarrassed to admit it, but there's a sense that like, we are not doing as well as we can with the data. And I don't think that's a fault necessarily of any of us. I think it's just a matter of we are all learning how to deal with these data. And I think the third point that clearly emerged is that this is not a phase we're going through. This is the future. This is the future. I hear everybody saying with great confidence that data is the way of the future, that we ultimately do not want to go back. We do not want to go back to decision-making being made on gut instinct. We actually want data to inform decision-making. And we also don't want to be in a world where the individual is devoid from her context. We want data about the determinants of the world around us. We want to know that decisions are being made that can improve my health by understanding what I need, but also in my context, as I think is true in Africa, as I think is true in Asia, as I think is true in Europe, as I think is true in South America. So data as a way of telling stories, data as something that reflects lived lives, data that reflects our experience individual with the context around us that can make for better decision-making to improve our health as a way of the future. And using the tools and the lenses to better understand it is clearly where we are all headed. And that, to my mind, creates opportunities for an interesting future. And I think if COVID and this moment has helped sharpen our thinking about that, I think that is all to the good, and I think we can all benefit from that. The 3D Commission will be moving forward with our work, and really we have 24 commissioners who have been gathering quite regularly to think about these issues and our goal in the next, in 2021, is to emerge with a report that synthesizes a lot of these issues that actually were surfaced today. Part of the goal of actually doing the side event was to really elevate these issues, to put them out there and to start the conversation. Because our goal as a commission is not so much to create something that exists only in the commission's brain, but actually to move this conversation forward. And having these kind of conversations is really what we are intending to do and what we're hoping will happen around the world. And we simply want to be part of the catalysis towards that, to have these conversations in multiple sectors. Because if we can emerge from COVID learning that, it will be at least some solace from this pandemic that really has galvanized and that really has transformed the world. I'm very grateful to everybody for joining. I realize how busy everybody is always, and particularly during this time. And I'm very grateful to everybody for overcoming all our usual sort of technological, logistical hurdles. In some respects, COVID has helped us all get closer to one another that way by teaching us how to use technology to actually be able to do things like this. And having said that, I also very much miss in-person meetings, and I look forward to an opportunity to continue these conversations in person. But most importantly, I really look forward to this conversation continuing, both here in the US and as well as all over the world in all of your countries. Thank you to all the participants. Thank you to all the speakers. Everybody have a wonderful morning, afternoon, and evening. Everybody stay well. Thank you.
Thank you.